All right, good evening, everyone, and thank you for joining us for tonight's Woo You event. We are blessed with Dr. Susan Resnick's presence tonight, and she's going to be telling us about debunking custom soft lens myths. I'm your host tonight. My name is Dr. Ariel Sorenzi. And a big thank you to Bausch& Lomb for exhibiting at this event. After the CE presentation, we will have the opportunity to hear from them, and you can ask any and all questions about their custom soft lens. This will be worth 1 hour of CE credit, so please be sure to attend for a minimum of 50 minutes. We will have a QR code at the end of the presentation, so you can use your OE Tracker app to scan that for instant credit. CE certificates will be provided to those with your OE tracker number, and it will be emailed to you within about 4 weeks. So please be sure to fill out the survey link that's in the chat, and it'll also be there when the webinar ends. We will save questions towards the end of the presentation. You can either ask that in the chat feature or in the Q&A. And then if you're on a phone, you can ask questions either in the Q&A at the top or under chat, which is under the three dots labeled more there at the bottom. So I'm excited to introduce our speaker tonight. Dr. Susan Resnick is a co-managing partner in a New York City and Long Island-based private specialty practice. Oh, sorry, could you go back?
Sorry.
Specialty group contact lens practice, which she joined upon graduation from SUNY in 1983. She is an administrator in the Vision Source Network, a diplomate in both the cornea and contact lens section of the American Academy of Optometry and the American Board of Optometry. She is a fellow of the Scleral Lens Education Society. Dr. Resnick is the editor-in-chief of the Clinical and Refractive Optometry Journal, as well as a contributing editorial advisor to optometric management and a contributor to Contact Lens Spectrum. She is frequently invited to speak on specialty lenses and practice management and has received numerous awards for her expertise in clinical care and mentorship. So, what a better person to talk with us about debunking custom soft lenses. So, we're excited to hear from you. And we'll just show your financial disclosures, all of which have been mitigated, and we'll have you take it from here.
Well, thank you, Dr. Sorenzi, and thank you to Dr. Wu for inviting me back, and to your team, which is just great. It makes everything so easy, and it's a pleasure to speak on this topic. And I was intrigued when Dr. Wu suggested this topic, and I thought, okay, there are myths about custom soft lenses, and I thought, well, there have to be, or she wouldn't have asked me to do this topic. So I had to sit down and come up with the myths. I came up with 7, lucky number. But if you have others that I haven't covered or touched on at the end, I think we'll have some time to go over them. Some of them, there are some overlap just by the nature of the topic. The other thing with respect to financial disclosure, I can't do a contact lens lecture without actually talking about design. And that to me is specific brands. So I will be talking about brands all in fair balance. And it's not to promote one over the other. It's just to show you how versatile and how different they are and how, they each have their customization specialties, and that's where it's going to be. And I'm going to give you a couple of cases at the end as well. So let's just start by taking a look at what we are currently doing in our prescribing of custom soft contact lenses. The data here is compiled for CL Spectrum readers, and it's compiled from industry experts as well. We can see that custom soft lenses, although well behind sclerals, are fit more frequently than corneal GPs in more than 50% of patients requiring specialty correction, and they actually outnumber hybrids in greater than 20% of patients. So look, the past few years, we all know whether you're a contact lens specialist or primary care, sclerals have been the bulk of the conversation. It's almost the, de rigueur choice in contact lenses. I will tell you in my practice, they are not. I have wonderful respect for scleral lenses, but as a practice where we see all kinds of patients with all kinds of problems, none of these lenses is out of my armamentarium. So I am reaching for all of these lenses at given instances. And tonight, I really want to share with you how versatile, the custom soft lens category is. And what's nice is that if you don't feel that comfortable with some of these other categories, they really aren't terribly different from fitting the commodity lenses. You just have to have a little bit more understanding of what we mean by fitting a custom soft lens. So here's myth number one, which we are going to debunk. Custom soft lenses are only for out of range refractive errors. So let's start with what these indications might be. So custom soft lenses are most commonly used for three main groups of patients, and those are people with eyes who have a unique size and shape. That can be a cornea that's large, flat, steep, small. Those who have a unique refractive error, high plus, um, high astigmatism, high irregular astigmatism, and those who have irregular astigmatism. But let's keep in mind these other perhaps less common applications. And so what I've come up with here is pupil size. There are patients, particularly young high myopes, who might be a simple -8 sphere, but are complaining about glare at night. I will often reach for a custom lens where the optic zone is bigger than the custom commodity 8.0 millimeters. Yes, you can correct some vertical phoria with some of these lenses. Typically, you can get about 4 base down prism in a well-made lens. Visual quality, there is some more aberration control in some of the designs, be it just better spherical aberration. And then there are some that also do aberration control based on population averaging of aberration, where they put some extra in. Think about your patient's quality of life and what other things they have going on, whether it's physical or environmental or even emotional. So may have a workplace or home environment that's not conducive to small GPs or even sclerals. If they have Parkinson's or they have trouble with manual dexterity or they have small apertures, you may need to choose a lens that fits that kind of challenge. Soft lenses are particularly helpful for patients who need stable post-lens wear refraction. We're all familiar with some of the spectacle blur that occur with GP lenses, but in my experience, you can also get them with hybrids and also with scleral lenses. Even though those lenses are not touching the cornea, there is a certain amount of change that occurs in the epithelium due to the osmotic effect of the post-lens or the pre-corneal, post-corneal tear film, pre-lens tear film. So I find oftentimes it is difficult sometimes getting a stable refraction after sclerals. And then there are patients who were referred into me because, their corneal specialist said, you have keratoconus, you need to go get a scleral lens. And they go to somebody else, and the doctor takes the physician's recommendation at face value. And no disrespect to our ophthalmological colleagues, but they really often don't know what's best for the patient and what the alternatives are. So I am always looking from a fresh standpoint at what will work better for this particular patient. So in order to dive a little deeper into custom lenses, we have to know what a custom lens is. How is it built? So for those of you old enough to remember Wild lenses, you'll remember that there was a base curve, a diameter, a power. Companies would offer various options. There would be multiple diameters, multiple base curves for a given material. And these were lathe cut lenses. And that's what custom lenses are. They're lathe cut so that they can be made to more specific parameters. Remember, commodity lenses are molded. And yes, they are made very, very well. But the reason they can be made in bulk is that it's pretty much a one size fits all lens. So what can be changed in a custom lens? You have the option of changing the base curve, the diameter, the power, the optic zone, the material, the thickness, in certain cases, the asphericity, prism, and again, aberration control. So just that alone gives you much more options in terms of managing whatever that person's profile may be, either visual, physical, or anatomical. So we talked about the fact that custom lenses have often been thought to be just, okay, the off-the-shelf lenses are not available in this person's prescription. They have 7 diopters of cylinder, or they have very large or very small corneas. But also, one of the myths is that custom soft lenses are only for irregular corneal shapes, and that's what we want to look at now. Let's just talk about sagittal depth. The one thing that we have to remember is that soft lenses are actually fit to the cornea. We take commodity lenses for granted because they are prefab and we don't have to think about it. They're essentially dumbed down. And I'm not suggesting that that's a problem. I mean, it's a beautiful thing. But when you have a cornea that requires a little bit of thought and a little bit more expertise, you want to be able to fit the lens. And the way you fit a lens is by looking at sagittal height. And the beauty of our now having experience with sclerals, as I teach my interns and I speak to other practitioners, everybody now knows what the effects are of sagittal height. So the proper fitting of a soft contact lens on the eye relies on matching the sagittal depth of the contact lens with the sagittal depth of the eye. And the corneal diameter, or the horizontal visible iris diameter, is the primary factor that determines the sagittal depth of the cornea, just like a scleral lens. So interestingly, after corneal diameter, corneal eccentricity, and that's the rate at which the cornea flattens from the center to the periphery, has the second greatest impact on fitting. And while the central corneal curvature is the least important, so when I see some of these threads on, let's say, ODs on Facebook or social media, where somebody says, oh, what's the steepest soft daily disposable soft lens? And everybody's talking about base curve. I cringe because you can't judge it by the base curve that those lenses are labeled. Those are labeled by the manufacturer to fit a vast majority of patients, roughly 87%. But it's geared to that particular material and that one diameter that the company is making. So think about this. One study found that the average HVID was about 11.8 to 12 millimeters with a range of about 10.2 to 13. Commercially available off-the-shelf lenses are manufactured to fit the average HVID, and that applies to about 70%, 77% of eyes. So roughly 25% of our patients should not be wearing commodity lenses. So now that you have that, you'll have a better understanding of as I go through some of these designs and what they can do. So we also need to think about proper lens fit. You probably learned this in school, but it might be a long time, but since you've thought about how is a soft lens supposed to fit and what the consequences of an ill-fitting lens are. And so while a one-size-fits-all soft lens is convenient, improper lens fit accounts for 25% or 20% of the annual dropout. A soft contact lens should overlap the limbus by at least 0.5 millimeters in all quadrants, and the general rule of thumb when determining lens diameter is to add 2 millimeters to the HVID, and that usually ensures a proper sufficient corneal coverage. So a large cornea fit with an off-the-shelf soft lens may not properly drape over the cornea. This can cause the lens to move excessively with the blink. There can be fluting of the edge. It can lead to mechanical irritation of the cornea and conjunctiva, as well as hyperemia. I would also strongly suggest that everybody flip lids on all patients. We think that, GPC is sort of like chickenpox, a thing of the past, but I will tell you it is still out there. I had a case came in today, and it's good to look at it to know because you definitely were going to want to change the edge design and or material of the lenses. And so, conversely, the same soft contact lens on a small cornea can result in a tight fit due to excessive sagittal depth. And this will reduce lens movement, inhibit tear exchange, and can lead to hypoxic stress. So if you have an abnormally thin tear film on both sides of the lens, and we know that the lens splits that tear film, if you have less than desirable tear exchange under the lens, that can cause dry eye, and it's also, again, a common cause of lens wear discontinuation. So think about these commodity lenses you're fitting and make sure that your patient isn't one of the 23% that can be wearing a better lens. Let's just look at some of the comparative fitting characteristics just to finalize our overview. So a flat fit on a soft contact lens is going to show excessive movement. It will induce some astigmatism. The over-refraction will show more plus than you expect based upon the spectacle correction. A toric lens is going to show rotation upon insertion, and it'll never really stabilize after the settling period. So if we compare that with a steep fit, the vision there is going to be inconsistent pretty much all the time. The vision will clear briefly post-blink. The over-refraction, conversely, here is going to show more minus. And toric lenses will show slow progressive movement of the cylinder axis away from its prime position. So it'll start off being, the axis marker will start off being where you expect it to be, but after about 10 or 15 minutes, it's going to start to either move temporally or nasally. My experience is that steeper lenses will tend to move nasally. Flatter lenses tend to move temporally. So it is a good idea, even though a lot of these commodity lenses now, they do position very, very quickly, and they are very, very stable. If you have an eye that has a larger HVID and is also has a steep keratometry, you have an eye with a higher sagittal depth. So I would keep the patient there about 10 or 15 minutes and look at that lens again to make sure it's not too steep or too flat. Okay, we're going to move to myth number 3. Custom soft lenses dry out quickly or are more comfortable, you're less comfortable. It is tough to deal with the comfort of these daily disposal and even reusable lenses on the market now. They are wonderful, but the reality is with customization, we can achieve comfort levels on par with commodity reusable lenses. And I've seen a lot of cases where I have patients and they tell me that their custom soft lenses are as comfortable as the daily wear lenses, of which 6 or 7 were tried elsewhere before they came to me. And I said, look, I'm glad you tried all these lenses. I would have done the same thing. And that's true. But, looking now a little bit more deeply at your corneal profile, your fit does not, and I don't try to make a big deal about it, but I'll say to the patient, you're not an off-the-shelf gal or you're not an off-the-shelf guy. Just telling them that they need a little bit more customization. So that's usually the verbiage that I use. So let's talk about material choices. We know that there are a lot of materials out there in our commodity lenses, but what do we have available to us with our custom lenses? And we have 2 broad material categories, just as we do with commodity lenses. We have HEMA-based polymers and silicone-based polymers. And while methylsilicon A was the traditional one, and it is extremely durable and had been used historically, most labs now offer hyoxysilicon. And hyoxysilicon has several advantages. It's a non-ionic lens, which means that it will attract less protein. Remember, lysozyme is attracted to negatively charged materials, of which the methylsilicon type lenses are. So having a non-ionic lens is able to repel the protein more. The beauty of hyoxysilicon is that it's available in 3 water contents, 49, 54, and 59. It's dehydration resistant. That's the glycerol methacrylate component. And it's also flexure resistant, which makes it an easy lens to lathe. If we look, I alluded before to the fact that commodity lenses were labeled with a single base curve and a single diameter for a single material. But when dealing with custom lenses and the availability of some different water contents, we can see here that water content actually does affect fit, even in the same base material. And this is a very nice illustration. It's taken from one of the specialty lens manufacturers, and it very nicely shows that the same base polymer needs to be adjusted for sagittal depth based upon the water content. So it shows that the HVID in the most common range of 11.6 to 12.0, and we can see that as the water content decreases for a given corneal diameter, a flatter base curve is indicated. So Keep in mind that if you do make a change from, let's say, a 59% to a 49%, you do have to adjust the base curve for a given diameter. So moving on to custom lenses and the material choices in the silicone category, well, here it's a lot more limited. Currently, the only available lathable silicone custom soft lens is Efrofilcon A, and this was introduced back in 2011, and it's a very good lens. It's definitive from Contact, and it has a DK of 60. It's a 74% water lens, and it has a modulus that's low, that approximates a HEMA lens, so it's very, very comfortable. And we all remember here, these graphs basically illustrate how the water content changes with the DK. So a lens with more water content, a silicone lens, will have a lower DK. Conversely, a higher DK will give the contact lens more stiffness. So there had to be a nice balancing act here between water content, DK, and modulus, and Efrofilcon does a very nice job of balancing all of those components. So let's move on to myth number 4. We've covered why regular corneas can benefit from contact lenses based upon the sagittal depth, why irregular corneas are not the only ones that can benefit. And we've talked about how the material makes a difference and that these lenses can be just as comfortable. And then myth number 4 for a lot of us or out there is that there isn't just enough need. Um, so this is interesting because a lot of the narrative out there with respect to contact lenses is that, well, I've kind of lost my interest and my passion for fitting contact lenses. I fit the lens and the patient just goes and orders it through a third party online. They're not ordering lenses from me. There's not enough money in it. There's too much chair time. But the bottom line is there is enough need. And if you start to look into custom lens fitting, and we'll get into how simple it really is in a few minutes, you will be really, I think, surprised at what you can do both for your patients and for your practice. So let's look at some of the special considerations for custom soft lenses. And I picked out 4. I don't want to say randomly. I thought these out. You may think of others, but I chose myopia control, anatomical, meaning conjunctival as well as corneal abnormalities, irregular cornea, and presbyopia. And so although there's a wide range of parameters available in commercially available extended range soft contact lenses, there are still parameter limitations that may inhibit patients from achieving their best vision. And custom soft lenses can be utilized for any refractive error, but perhaps where they're especially beneficial is via the opportunity to provide an optically superior outcome for presbyopia. And I'm going to go into more detail on that in a moment. And being able to tailor the lens to the specific anatomical and distinct visual demands can only improve the success. So in addition to patients who have regular corneas, we also can fit custom soft lenses for irregular corneas. But understanding the difference in lens evaluation and setting patient expectation are keys for success with these patients, and we're going to talk about that in a moment. Patients who have high regular or irregular astigmatism, post-surgical corneas, post-corneal collagen cross-linking, keratoconus, intolerance to GP lenses can be quite successful with custom soft lenses. And the thing about it is they may be less intimidating than corneal GP hybrid or scleral lenses. And so, this is where I think soft lenses come into play. And then for those of you that do a lot of scleral lens fitting, but are not quite up to wanting to deal with the customization of the edge design to accommodate pterygia pinguecula or blebs, certainly soft lenses, if you can use them, make things a whole lot easier. So let's go into a little bit of more detail about the challenges of presbyopia. With the rapidly growing demographic of this population, more tools in the box are always welcome. We know that presbyopia is a challenge, and as good as lenses are, we all know we want better and we need better. Custom soft lenses provide a significantly expanded opportunity to take patients from good enough to wow. How can we do that? You can correct even small amounts of cylinder. You can have the lens centering better. Remember, sagittal depth. The central zone size is controlled, and that's what controls the vision. And then the peripheral zone is dependent upon the pupil size, and we can vary that. The general recommendation, by the way, from most companies is to start with near center in both eyes. And when you're troubleshooting, it involves altering the zone size, not the add amount. Keep that in mind. So, for instance, if you're going to improve distance vision, you're going to decrease the center zone. To improve near vision, you're going to increase the center zone. So here's another tool that I put up just for illustration, where it actually is a simulation tool where you can put in the patient's, the type of multifocal you want, near center, distance center, the add power, and the pupil size. And on the bottom, it kind of gives you a visualization of in what range is the vision going to be the best? Is it going to be biased towards the near, the intermediate, or the distance? So it's a very nice way of looking to see how your lens design is going to impact a particular patient with a particular pupil size. And we all know that when we're fitting multifocal lenses, the first thing we want to do is find out what the patient does most of the time. We know that these lenses can't be all things to all people all the time. So we want to bias them to what they're mostly looking at. Are they mostly doing computer? Is their world mostly distance biased and they just need to, be able to see their phone or their GPS from time to time? Or are they sitting and doing needlepoint and they have less concerns about their distance vision? So these are all things that we want to take into account. And this tool is a nice way to kind of visualize, if you will, for the doctor to see what is going to happen. So getting to another feature of custom multifocal lenses, we can consider how misaligned optics can be compensated for. How do you know if a patient has misaligned optics? We're going to get to that in a minute. But without actually doing the topographies, which I'm going to describe in a moment, if you've been working really hard with commodity lenses or even with custom custom soft lenses, and you're getting the visual acuity, meaning the patient can read, but they're seeing all sorts of glare, haloing, or even sort of a three-dimensional type of thing, that usually indicates that the optics are misaligned for that patient. That can be due to either two factors. It could be due to angle kappa, which we'll go over in a minute, or it can be due to the fact that the lens is not centering perfectly. So offset optics compensate for lens decentration or significant angle kappa by shifting the multifocal optics from the geometric center of the lens to the patient's line of fixation. So just to review, angle kappa is the angle between the visual axis and the pupillary axis. So the light reflexes near the visual axis at the corneal plane, and the average angle kappa is plus or minus 5 degrees. So patients with angle kappas larger than that are the ones that are going to be complaining. Also, it's interesting, studies have shown that hyperopic patients tend to possess larger angle kappas. So keep that in mind for your hyperopes where you still can't get, the adequate, or, they're still dissatisfied with their lenses. So how do you identify optical misalignment? The best way is to determine angle kappa is to look at three maps. And you're going to be using the tangential maps as well as the topographer's comparative or difference display setting. So first do a topography on the naked eye, then take another scan with the multifocal lens on the eye, and then you're going to use your subtractive map and the cursor to measure the linear difference between the center of the lens optics and the patient's visual axis. Now, you can do it by simply performing topography over the lens, but it's more difficult to see the center of the optics in relation to the visual axis. So keep in mind that the rule of thumb is that if there is 0.5 millimeters or more of misalignment, the patient will likely experience improved vision with offset optics, and there are manufacturers that will do this. So moving to the next subspecialty of application where the need may be for custom lenses, often overlooked is customizing myopia management. You'll remember that in a single vision contact lens, it focuses the distance vision behind the retina, on the retina, I should say, but the peripheral light is focused behind the retina. So we're looking to use a distance center lens, which brings the light back to the retina and the peripheral light in front of the retina. And this signals the eye to grow more slowly. So how can we use this concept to control myopia? There are several things we can do that are advantageous over what's available now in terms of the ready-made myopia control lenses. First of all, we're dealing with children, and so we know that children's corneas have a much lower sagittal depth because their HVID is often a little bit smaller. The other thing that we're lacking in these ready-to-made, specifically the daily disposable lenses, is incorporating cylinder. So it's very frustrating if you have a child that comes in and, they have one diopter or 1.25 diopters either against the rule or um, oblique, and you're not going to get that child to see as well as you want them for school. Look, we know that if you put a spherical lens on a child who has toricity, it's still going to have some benefit, but you then might still need to prescribe some glasses for over the lens. For those of you that do overnight ortho, okay, obviously that's not quite the problem, but there are lots of parents who still want, or you may choose to use a soft contact lens instead. Again, here we can customize the central and near zones. Remember that we want to have an optic zone, a near, a distant zone, much smaller in these children. So they're getting a lot more of that near peripheral blur. So we want to make these zones smaller, just as we do in ortho K lenses. We do it differently for children than for adults. And we can also choose between annular or aspheric designs. We may find that one just gives better vision than the other. I can't tell you that I know of any studies that have actually looked specifically at the efficacy of these two different designs, but if you're getting roughly +3 in the periphery of that child's eye, whether it's an aspheric or an annular, I would say you're good to go. Let's move on to that next category, and that is irregular corneas. Looking at custom soft lenses for ectasia, again, a person walks in with keratoconus or post-surgical ectasia, and, immediately a lot of us are thinking of scleral lenses. But soft lenses are really a big player, and in my practice, they are, I would say, 20% of patients coming in referred to me with keratoconus are going into custom soft lenses. And they can benefit from it if they're GP intolerant, if their lens wear is limited, if they can't wear a hybrid, they can't wear a scleral. And while many corrected patients are able to see, the quality of life is adversely impacted. I've had lots of patients come in who say, yeah, my vision's great with my sclerals, but I really hate having the way I have to put them in, take them out. I have to carry too much equipment with me. I mean, they come in with all sorts of problems, and part of me is like, oh, how could you complain? You're seeing so beautifully. But just remember, these are people, and they have different lifestyles and different tolerances for convenience. In terms of soft lenses, obviously we know that typical soft lenses for keratoconus may not meet patients' needs. In the very early stages of keratoconus, yes, there are some commodity lenses on the market, some reusable lenses where we can do extended range and get pretty good vision. But generally, in order to mask more of the irregularity, you're going to want to use a custom soft lens. So let's talk about these custom soft lenses. Although gas permeable lenses allow for better visual acuity as they pertain to irregular astigmatism. Custom soft lenses may offer better initial comfort, centration, and some improvement to vision over spectacles or uncorrected vision. And so there are an increasing number of lathe cut soft irregular cornea designs available from different laboratories, and they're distinct from standard soft lenses in that they follow one of two fitting premises. They have an increased center thickness to mask the irregular astigmatism, or they utilize an aspheric design to limit aberrations. And most custom soft lenses are fit with diagnostic fitting set. However, they can also be ordered empirically. And an increasing number of custom soft lenses can be designed using software compatible with, um, topography and profilometry. And regardless of the lens design that you're using, it's recommended to follow the manufacturer's fitting guide for the selection, evaluation, and troubleshooting. So these lenses are available in almost unlimited spherical and cylindrical parameters. They go around the clock. The difference with these lenses is that the base curves are designed to match the average central corneal Ks. And the base curve in the optic zone is what's going to give you your fit over the central apex of the cornea and is also the zone which contains the refractive component, the power. But it's the intermediate curves that actually control the fitting of the lens. And we're going to talk about that in a moment. The center thickness may be modifiable. There's one design or a couple designs that do that. And again, you can also, there are others that you're basically just pumping up the amount of cylinder in the lens, and they use advanced aberration controls. And it's the peripheral curves that are available for fit to the normal corneal tissue. So once you've established that fitting relationship in terms of the center of the lens, then you are making any changes based upon the intermediate or peripheral curves. And then the edges are going to be thin in these lenses to promote oxygen delivery and also to promote comfort. Now, a question that often comes up is, well, there are a couple of brands, and one of them I really like, but it's in hyoxysilicon, and that's not a silicone hydrogel. Dr. Resnick, are you concerned about oxygen? Well, of course, I'm always concerned about oxygen, but I will tell you that all my years of fitting these custom soft lenses, whether they are HEMA-based materials or silicone materials, I've never once had a problem with anoxic changes, be it corneal edema or neovascularization. And the reason is these lenses actually pump, there's a great tear exchange because of the lenses are a little bit thicker, they're going to move about a millimeter or so with the blink and still be very comfortable. So you're getting enough tear exchange through these lenses. The other reason is that even in the toric lenses, there's not really thick prism ballasting. These lenses use designs where the edges are thinned, and that's how these lenses are stabilized. So again, the thinness of the lens and the movement of the lens helps promote the oxygen. You have one brand here that you actually control the different quadrants of the lens so that if you have fluting in one area or the other, you can actually have the manufacturer tighten up either the superior or inferior aspect of the lens. So that's done typically with one of the silicone brands. Silicone, as you know, is a stiffer material. You're more likely to get fluting. If you're using the hyoxysilicon-based designs and you're choosing the right diameter, you will rarely get fluting, if ever. So I alluded to how you fit these lenses a moment ago about choosing the proper base curve as your first step. And what I like to do is I like to use high molecular weight fluorescein. I put the lens on the eye, I let it settle a bit, and then I apply the fluorescein to the superior conjunctiva. I have the patient blink for a few seconds and I just look at the pattern. And while there are manufacturers, if you look closely at the fitting guides and the fitting sets, which I'm going to show you in a minute, there's really not a whole lot of difference. They all have the basic premise in how you fit their lenses. It may be a little different based upon their design, but they're really very, very similar. And so most of them are going to tell you to have a lens which just gives a very, very light central touch. And you're going to see that in that middle slide there, the middle picture. You can use diffuse lighting like it's shown on top. And you can also use a parallel pipe head shown on the bottom, much like you would look at a scleral lens. So you're looking for this very, very light central touch. That will ensure that you don't get a lot or disruption to the epithelium. But at the same time, that very, very light pressure, it's not so much a pressure, but it's really alignment, is going to give you better visual acuity. Another way to know or to evaluate how good your patient is good or how well your patient's going to see with your soft custom lens, whether it be the design that you can change the thickness with, or another design where you can just maybe increase the cylinder, but most of the designs will allow you to customize the thickness. Um, Look at the keratometry Myers over the lens. It's just so easy to do after lens has settled. And the keratometry Myers over the lens will be crisp and clear with the proper thickness. So that's just a really nice way to make sure that you have chosen the proper thickness. Um, let's see now. So we've covered irregular lenses, irregular corneas. We've covered myopia management. We've covered presbyopia. So let's go to things which are maybe not quite as common, but I find that I get plenty of referrals from our corneal specialists for lots of crazy corneas and crazy eye disease. And, again, while we have sclerals and we have membranes and all of these nice new fancy tools, I will share with you that I'm a bit old-fashioned and I still go to soft lenses as my medical fitting for most of these problems. So these can include bleb leaks, which some of you may not be familiar with the newer glaucoma surgeries. We rarely see blebs, but we still sometimes do. Iris coloboma, just these other two are just examples of when I would choose the prosthetic design. So for those of you who do see a lot of glaucoma and a lot of post-glaucoma surgery, let's just talk a little bit about bleb leaks. You can get a very, very large HEMA, custom diameter. We're talking often 17, 18 millimeters because you want to get it over the bleb, sometimes 19 millimeters. You're going to tamponade it. This can be for early or late stage bleb leaks. And what does it do? It facilitates reepithelialization over the wound margin. Remember, these surgeons are applying medicines which retard the healing to keep the blood going. And sometimes they use too much mitomycin C and they get post-surgical bleb leaks. So you're going to cover the superior conjunctiva with a minimum of 2 to 3 millimeters above the limbus. You're going to check the fit after 30 minutes. And you're going to make sure there's no air bubble and make sure there's adequate coverage and proper movement. And you will have the patient sleep in these lenses for a few days. It's off label, of course, to sleep in them, but certainly you want to save the eye from having too much fluid leaking. That's a Seidel sign. I'm sure everybody knows that. So then there's custom and prosthetic designs for the trauma, for the scarred pupil or misformed iris. This just shows the various designs. You can have a central black pupil and have a clear periphery if you just want to block out a central scar and not change the color. If you need to put tint on a lens, you could use a design like an A where you can do a black backing. You can either do hand painted or have, there are lenses that are a kind of ready-made in these designs. So keep in mind that cosmetic and prosthetic designs are still a very important area of custom soft contact lenses. Here's an example of a patient that I had not that long ago. He was post-complex cataract surgeon. You can see his left eye, he had a fixed and dilated pupil. So I ordered an opaque tint because he had this blue-gray kind of eye. I had to use a black-backed iris, and This isn't a hand-painted lens. This is one of the manufacturers where I was able to get a print that matched his slate gray eye. He did not require any correction, so I was just able to use a clear pupil in a plano prescription. So this patient, very, very happy. Okay, we're getting there, folks. 3 more myths to go. Myth number 5, you must be a contact lens specialist. The beauty of custom soft contact lens fitting is that you do not have to specialize in contact lenses. Let's see why. First of all, there is no extra equipment required. All you might want to have on hand is some high molecular weight fluorescein, because you can use that with your hemo lenses. You can use regular fluorescein, by the way, for your silicone-based lenses. Have a millimeter ruler. I alluded to the fact that a lot of these designs, or certainly the presbyopic designs, and the myopia control designs, you're going to want to have really accurate measurements of the pupil. And I know that your topographers give you this. It's interesting because I have different topographers and they'll each give me different pupil sizes. So some of the companies will actually ask you which device you used. I still prefer the good old-fashioned millimeter ruler, or else I use the reticle on my slit lamp to measure pupil size, and that's the most accurate. Having an anterior segment camera or a cell phone works well too, because if you're dealing with a consultant and you want to show them something on there, it's also good for documenting when you have something that comes in that's not, that's a medical cornea or scarring or neo. It's always good to make sure you have pre-fitting documentation so that you can just assure yourself that the adverse effects you may see going forward are not going to be due to the contact lenses. It's usually due to the condition itself. Bigger stuff needed, you're going to need your slit lamp and you're going to need your topographer. So here's, again, this is equipment we all have, and you don't have to be a corneal specialist or a contact lens specialist to do it. So for regular corneas, no fit sets are required. Empirical ordering, Ks, HVID, refraction. For multifocals, you just need the ad and the pupil size, and you want to give the photopic pupil size. And so this is just taken from Bausch & Lomb's new Revive lens, which is a wonderful lens. And what they've done is they've made it easy in 4 steps. And basically, you just do these 4 things. There is a fitting guide if you just want to look it up yourself. And what they've done is they know how their lens is supposed to fit in a given diameter with a given base curve. So they've kind of made it a little bit easier for you in terms of grouping it. But you don't have to look at that. You can just call their wonderful consultants, give them this information. They will send you the first pair. And, you see how that goes. And if there's any troubleshooting, just take really good notes, do a careful over refraction, and then you can report back to them and they'll help you troubleshoot as well. Once you've done your first 2 or 3 patients, I say you're over the learning curve with these, as with most custom soft lenses. What about irregular corneas? Well, for this, I strongly suggest fitting sets. They are very compact. The one on top here is for Bausch & Lomb's Novacone. The one on the bottom here is for Excel's Flex Lens Arc. And again, if you look at the fitting guides and the fitting sets even, they're very, very similar. Novacone is great because you can change the thickness of the lens. It's a very intuitive lens to fit, and the Flex lens also, the difference with the Flex lens is that there are 2 materials available, and so you just have to change it up a little bit if you go to the silicone hydrogel material. But the point of this is that both companies are great, but you just want to, for these instances, you do want to have the fitting sets. And again, they're very, very small fitting sets. It's not a big investment. You're not alone. You have many resources, laboratory consultants. All of the companies have online training. A great resource, by the way, is gpli.info, and they have Ask an Expert. I just showed you a little clip here of what you do. You just put in your basic information. And one of us on the advisory panel will get back to you regarding, whatever you're fitting. And, we think of GPLI, it stands for gas permeable, but we do a lot of custom soft lens fittings in the GPLI as well. And there are journal articles. Yours truly has written a few. And we keep pretty current: contact lens spectrum, optometric management. You can look it up, just do a search and you can pretty much get everything. And then, ask a friend. Feel free to call me anytime you want. If you have a patient in the chair, I'm always happy to help. Okay, so myth number 6. Contact lenses are prohibitively expensive. Well, I don't know. Let's talk about this. I don't think so. Let's look at the cost considerations. First of all, let's talk about us. Practice. Full credit within 90 days, no lens return if the fit is successful, and typically unlimited exchanges. You have nothing to lose. You have everything to gain in making your patient happy. If they're coming to you and unhappy with their commodity lenses, or coming to you with an irregular cornea, or needing a prosthetic, it just behooves you to just delve in. Don't let anything intimidate you. I've already talked about the fact that these lenses, when you think about fitting a custom soft lens, you're really looking for the same exact things you're looking for in your commodity lenses. A little movement on the blink, good corneal coverage, good endpoint refraction. And really that's what you are looking for. So the average, and these are just, estimates, everybody. I can't tell you what I'm charging, what anybody's fitting, but this is just sort of averaging out people I've spoken to over the years. So the average annual lens cost for, a specialty soft lens would be about $1,000. If you compare it to a premium daily disposable toric, that would be about $800. So you're not talking about a whole lot of big bucks to have a happy patient. And certainly I don't think $200 to your patient is going to make a difference. Think about scleral lenses. The biannual cost there is $800. And if you think about biannual hybrid lenses, it's $1,500. So yeah, there's a little bit more of cost to the patient, but I've never had a patient complain about the cost when they saw the results. Myth number 7. This is the final myth. Custom soft lens fitting is not worth the time. So as we know, value is in the eyes of the beholder, no pun intended. So if you charge adequately for your time, the professional and financial rewards are returned in multiples. So here, what did the experts say? You don't have to trust me. This was printed in Contact Lens Spectrum, and this is only from about 5 years ago. And a survey was sent to the members of the Academy and to describe their utilization of custom soft lenses. 124 of us responded. About 80% of us reported that we prescribe custom lenses to manage astigmatism, presbyopia, refractive error, as well as for myopia management, and to retain contact lens prescriptions. And when we were asked to identify the most important characteristics to define custom soft lens success, 21% stability of vision, 38% comfort, and 21 selected visual acuity. I think it's surprising that most of us chose comfort, because again, we often think that we are only picking these lenses for the crazy prescriptions. But again, for these patients who have parameters that are outside those commodity parameters, the corneas are, the lids are so much more comfortable and the corneas are so much healthier. All right, so we do still have a few more minutes. I'm going to just go through some real life cases. I just want to give you an idea of what I do in my practice. So I've picked 2. First one, I'm going to talk about irregular cornea, and the second one, I'm going to talk about presbyopia. So here's a lovely young woman. She came in a few years ago. She's 40 years old, and she has keratoconus. She was post cross-linking, and she had also had intacts. Um, quite the quite the cornea. Anyway, she was originally diagnosed with keratoconus several years prior to laser screening. I have to tell you, my biggest admiration for laser screenings, or how much more keratoconus we've picked up over the years. She had tried soft toric lenses with dry eye symptoms and what she described as soft vision. And she really wanted to optimize her wearing time, less dryness, but she also wanted to be able to go back between contact lenses and her glasses. And she was lucky in that even though she had keratoconus, she had mild keratoconus. And so she was still able to wear glasses. So she didn't want to wear any contact lenses that were going to cause any kind of spectacle blur. So here you have the data. You can see the topography was almost like a pellucid-like shape. So again, her VA with her habitual specs was in the 20/30 range. Look at the difference between the right eye and the left eye, 450, and it's kind of interesting that she didn't see that much worse. Intacs can do that, so that's the one advantage. We all know, though, how sometimes Intacs makes contact lens fitting miserable, which is why I love soft lenses for these patients. She actually had the Intacs in both eyes, and she also had a conductive keratoplasty burn in her right eye at 11:30. So she went to a practitioner that pretty much threw the kitchen sink at her surgically. So her options, again, were any of the above. My fitting plan was to go to soft toric design and to manage her underlying dry eye symptoms. I put on some diagnostic lenses. I used a design that I was capable of managing the thickness. The IT of 2 meant that it was 0.1 millimeters thicker than an IT of 1. I did a spherocylindrical over-refraction. She was correctable to 2020 and 2025. And so I ordered the lenses just as is. The base curve and diameter was based upon this particular design. You took the average Ks, and their standard diameters was 15.0, which basically fits about 90% of patients. So we dispensed her lenses. She was 20/25 in each eye, good movement, over refraction, looked really good. Managed her dry eye symptoms. By the way, I'm not going to go into that. That's a dry eye lecture, but we put her on multi-purpose disinfection. By the way, in these thicker lenses, I prefer multi-purpose to peroxide. Sometimes the peroxide gets held up in the lens and doesn't neutralize, can cause singing. So I would avoid clear care on these chubbier lenses. She built up to 8 hours, and I followed her up in a week. And she 10 to 12 hours of wear. She was 20/25, 20/20 OU, but she wanted better vision, of course, right? So I calculated the resultant, and I did a final dispensing, and that was the final lens. And she's 20/20 and no rotation, and she continues to do well. So you see, this wasn't that much more difficult than fitting an off-the-shelf lens. It was basically selecting the diagnostics from my little fitting set, doing it over refraction, and not much different. So she's very happy. The second case, just to show you, this was a compound hyperopic astigmatism and presbyopia. This is a very interesting gentleman. He actually is not just a photographer, but a cameraman. He works on Broadway. My practice, for those of you that don't know, is Upper East Side of Manhattan. I see a lot of Broadway people. He had previously been fit with soft torics with monovision. Cameramen typically don't like monovision. Well, sometimes they don't, sometimes they do. They have to look at the camera. They have to look at the settings on their camera. But, and he was okay for that, but in his photography world, he wanted better depth perception, and he wanted to be able to see both the subject and the camera setting without glasses. And he also was very physically sensitive. So I refracted him. Yes, this is one of my easy patients, by the way. 250 ad, high hyperope with cylinder, average Ks, left eye dominant, pupil size 5 millimeters, scotopic 3 millimeters, mesopic. He had average HVID of 11.8. Again, I had all the tools I could, but he elected to begin with soft lenses. He didn't want to have to learn anything new, and he wanted to be able to transfer quickly between the seals and the spectacles. So I chose custom soft toric multifocals, try to get consistent rotation and best VA. Again, this is a place where you can actually put in all the information. It'll generate a lens. It'll show you what you wind up with. So it's a very nice way to enter into fitting multifocal specialty lenses. Another wonderful way is the Bausch and Lomb lens. Take the measurements, as I described before. There were 4 steps. Interestingly, they actually give you a little bit of guide here so that if you want to do it by yourself, you can. You change it up a little bit depending upon the patient's distance refractive error and what their ad and their pupil size would be. And again, just keep in mind when you're fitting multifocal lenses, you're going to develop an ad based upon the patient's working distance and their age generally. In order to perfect the vision, it's the pupil zone size that you're changing. You're not messing with the ads. So I ordered some lenses for him in hyoxyfilcon material. I did a near center design. Given his pupil size, we selected a 1.8 millimeter lens. Visual acuity was better than 20/25, monocularly 20/20 with both eyes. He reported great vision, and he still continues to wear these lenses. I got really lucky here. My first order is what he ended up leaving with. So to wrap up, practice benefits, better clinical outcomes, certainly enhanced patient loyalty. I mean, to me, you know, passion is a two-way street. If the patient's not happy, I kind of lose my passion as well. It really bugs me when patients aren't happy. So I always want them to be happy because it's how I get my gratification professionally. Um, what makes me happy too? No alternative sourcing. These patients come back. I could probably never send out a recall. They're going to come back. They certainly refer a lot of patients. I feel covered because of the liberal warranties and return policies. I get the lenses quickly. It differentiates my practice. The most exciting thing for me is that my staff loves dealing with the consultants in these companies. They just don't have enough positive things to say about the consultants. So, my staff, if I fit custom soft lenses on every patient, I would have the happiest staff.